All right. Hello, and welcome again to another Down Fracture podcast, a podcast for talking jaws. Per usual, Dr. Mike Watson here with Dr. Sam Bobek. What up, Sam?
Not much. How about the Mariners?
You are not as worried about them as I am.
No, I am not worried about the Mariners. We actually made it in the playoffs. It's something to celebrate. Don't let it stress you out.
Yeah, I think that's the problem. I should just be happy that both the Cubs and the Mariners are in the playoffs.
That would be the dream World Series. Brewers, Mariners, I'd take that. That'd be fun too. I'm excited. October baseball is here this week, so should be good.
I might actually have to watch a game. I almost never watch unless I go, and I just kind of follow it. But I'm a little bit excited. I may have to watch it if football's not on.
Yeah, I
Um, well, what else is new? Okay, so downfracturepodcast@gmail.com. Again, continue to get emails. Please don't think we're ignoring them.
think we got some good feedback on hardware removal. I
Yeah.
can't believe we didn't mention the piezotome to take bone out of the screwdriver head. So thanks for mentioning that. I
Yeah,
think people
I don't know that we were clear. We talked about osteotomes, we talked about screwdrivers and things like that, but there was also the mention of putting the screwdriver within the screw hex and malleting it gently to free up the bone. And I don't know that we directly talked about that. So that was another
Yep.
thing mentioned that you can do. I mean, for me, it's just kind of all of those things and trying to figure out what works, and what works the first time doesn't work the second time. And then the next case is something different and figuring it out. All right. Yeah, hit us up. We do read, we do take into consideration a lot of the topics we keep on our list, and we'll get to at some point. Some of them we want to try to bring guests on and other things for. So coordinating all that can take time, so don't think we're ignoring you. Please, the feedback is welcome and appreciated. And then today we're talking about some more stuff, right? What kind of stuff?
Yeah, I think MMA in patients who have condylar resorption.
Okay. Has this ever happened to you? Probably not, right?
Oh yeah. I mean, I like this topic for a number of reasons because this is kind of like plates and screws in the mandible kind of topic with surgeons, right? Like there's people who only do joint replacement, then there's people who only do sagittal osteotomies, and then only ramus osteotomies. You know what I mean? Like
Yep.
it seems like there's different camps, so it's good to talk this one out.
Well, yeah, I think I mean, just to get to basics and set the table here is we were probably all trained. I was, I'm assuming you were. I keep hearing it from, whenever I discuss this, that there's basically two ways to go. One of them is joint replacement or some kind of condylar replacement, whatever you're going to do. But for argument's sake, let's just say total joint replacement with alloplastic joints, or trying to arrest the condylar resorption or letting it essentially burn out. Like let it just do its thing. And when we're confident that it's stable, reasonable to just do MMA alone. Is that
Well,
kind of how you
because
were trained?
I would narrow this topic down. So I took our title to mean patients who are coming in for breathing better. So
Yeah.
MMA, as I understand that terminology, is performing upper and lower jaw surgery of some flavor to expand the upper airway as the primary goal.
Yep.
So it's not orthognathic surgery, it's not aesthetic surgery, it is airway surgery. Is that how you understand MMA? Or I know people use that term to also mean orthognathic surgery where you're advancing the jaws, but I think when I think of the term MMA and condylar resorption, it's really patients who are showing up because they can't breathe, and we want to expand their upper airway in some way, and they have condyles that have either resorbed in the past or actively resorbing. And what to do in that patient group is how I perceive this. So
Yeah. Yeah, no, I think that's what we're getting at. But from that standpoint, aren't your management strategies essentially replacing the joint and using that to advance the mandible and then doing maxillary orthognathic surgery, or accepting it as being resorbing and trying to stop it, and then and or waiting for it to just do its thing, and when you feel confident that it's no longer resorbing, treating them just with MMA and traditional orthognathic surgery?
Yeah, this was tough. I feel like because I was taught different things depending on the attending, right? And I think they're all right. I feel like there's individual patients that fit into both of the philosophies. The one that seems most popular is that even though the joints look bad on X-ray, if they don't look bad clinically, then you keep the joints. So that philosophy. Um, and then the other one, which is if the joints aren't working, then you treat the joints. From a patient perspective, I think frequently patients are unaware that joint replacement advances the mandible. Like MMA is just BSSO Lafort because that's what it was in, like 1984 when it was first described. And so using the joint replacement devices to advance the mandible, I think in some patients makes sense more so than the generic joints look bad in imaging but look good clinically, leave them. And then if they look bad clinically, then replace them. How do you practice?
I mean, do you want the short answer or the long answer?
I'll take short and long. Let's start with the short.
The short is exactly as you said, but I discuss both options with the patient and go
Sure.
through pros and cons like we all do, right? The long version would be that I tend to prefer, I think, joint replacement, and for a number of reasons. I would throw out that, frequently when we're talking about condylar resorption, especially if we're talking about ICR, idiopathic condylar resorption, we can be talking about younger patients. Although the one I'm showing an image of is on the screen, and that is not the case. This is a middle-aged patient who has a history of it and now wants to deal with it. But if I tend to like the joint replacement because, I'm looking at these condyles on the screen here, and for those of you who can't see this well-edited and extravagant image that we have on the screen here, that may or may not be from a PowerPoint presentation we put together 7 minutes ago. Patient has just completely flattened condyles, like there's barely any condylar process left. Um, Not a lot there. Um, but I look at that and I say a few things. One, when I'm trying to seat those intraoperatively, I don't think it's a given that I'm going to seat each side correctly or either side correctly. When I'm doing the sagittal split and trying to put things there, I think that makes the sagittal split less predictable, more complicated from a seating of the condyle, final occlusion, midline discrepancy scenario. I also don't know how well those condyles are going to hold up long term. And so, what if we get a good result and then 5 years from now we're doing this again because they continue to remodel, resorb, we trend towards open bite, class two, whatever it may be, asymmetry. So all those things are kind of running through my mind, and I think generally most of us as surgeons we say, we want to solve the problem and hopefully do it in one operation. With that mindset, I don't know that I can. I feel really confident that feeling that I can do that with just orthognathic surgery in these patients with significant condylar resorption. Now you could flip that on its head and you can say, wow, look at those condyles. What is left to resorb? And there's nothing left to resorb. And so the likelihood of a middle-aged patient who has decent function and has this level of resorption, like there's nothing left to resorb. Just do the orthognathic surgery. The joints are functional. There's not a pain component. Just leave the joints as they are and do traditional MMA with orthognathic surgery. So, I mean, there's a lot that goes through my mind, but I think, as you've said many times on here, I feel like patients just generally do better when you treat their pathology. And in this case, the pathology may be somewhat arrested, but the pathology originated with joint, with condylar resorption of some kind. And addressing that in the way of a joint replacement, I think more predictably gets them to a stable solution. But as in this case, I give them the option. Here's pros, cons, and they decide. And in this one, it was just orthognathic surgery.
Yeah, but if this is your sister or your wife, what are you doing?
I'm sending them somewhere else. I'm not dealing with either of those two people.
But
No, I mean, I think it's a fair question for a family member. Or like, I still would have the same, I think, discussion. I think I would still do the same thing.
but if
Um,
I had to, because you're going back and forth, and I understand going back and forth because both thoughts I think are true, because both answers are right. Like there isn't a bad answer on this, and I think it's why people practice in both ways. But
Well, what I
if
would
you were going to hang your hat on it, like you had to make the decision, this is what we're doing here. What are you doing here?
in this specific situation or in generality?
In this situation, let's say a mid 30-year-old person who comes in with a history of condylar resorption, joints function well, radiographically they look like garbage, and you need to advance them more than a centimeter and a half.
I still think I lean joint replacement there, to be honest with you, because I mean, I think the reason people avoid joint replacement largely is for perceived complications with it. And I think when you try to do an operation to avoid another one, the worst case scenario is you end up doing both and you assume the risk, complication, potential, cost, everything of both operations. And so I think the ultimate way to have the least amount of risk and totality for the patient is to do one surgery.
Yep.
And I think in this case, that's TMJR.
Yeah, I know. I think I definitely trend towards that same thing. I feel like that's been a big difference in my practice over the last decade. Because with TJR, it wasn't until relatively recently that we kind of trusted these things long term, because the devices, like the original Vitec device, and let's say I don't know, like the Christensen or the Hemi joint, those ran into trouble, and people, you don't want to have multiple surgeries. It seems with TJR that you would expect 30 years out of them. It could be that we could expect 50 years out of them. They just haven't been around that long. And the other side of moving to Seattle for me is that I saw people who had MMAs with condylar resorption in the 90s or the 2000s, and then they come back late. Because you really don't want to have two surgeries, right? So to me, I think it's the trend in my practice has been towards joint replacement, not away from it in this subgroup. And unless something changes, I imagine it continuing on that path, even though I practice in both ways, just like you do, right? Like, because patients have um preferences, because TJR is more expensive, right? Not more expensive than some of the fancy Ramus osteotomies that are out there, like the Z's and the L's, all that sort of thing. But still, it's more expensive than a sagittal osteotomy in terms of hardware.
The
But
most expensive is doing both.
the concern that I have is people who come in that are in good shape functionally is that they're adapted to their current state and they're doing well. And then we're going to put them through a big operation and the chin moves forward an inch, let's say 2.5 centimeters, right? And in that newly advanced position, the joints can be stressed out. And that's a real thing. It's just hard to identify who that's going to be. And a little bit of condylar resorption is no big deal. It's the people that have already resorbed have proven themselves to be of the physiology to resorb. And I don't currently practice in the way of recommending MMA and everyone like that. But if they're just little sticks of condyles, it's a real risk that they resorb after the fact. And as long as everyone's on board with that, then you can obviously just do the TJR, ever 1, 2, 10, 15 years later. But I think there should be a discussion at least on joint replacement. One of the sneaky benefits of joint replacement, I would say the two sneaky benefits, I think it's a better contour of the mandible reconstruction. I think you get better angles. It's the best way for jawline aesthetics because you're restoring the lost height with TJR, by the way, in this
Right.
subgroup. And then the risk of numbness is less. Obviously, you bring up facial weakness, which luckily is a low rate. But I think the hypothetical patient that we were discussing, and I asked you about the 30-year-old. I mean, if it's a 60-year-old or a 70-year-old, I mean, joint replacement, I think, is a much easier thing to go through than an MMA. Like a 65-year-old lady with severe obstructive sleep apnea and arthritis in her joints, I have a hard time recommending anything other than joint replacement before. Just because a sagittal osteotomy is a big operation and rates of dysthesia are non-zero. The rates of bone infection are non-zero. The things you don't really see in the younger population exist. And so I think there's a good case to be made with joint replacement.
I do too. I mean, I'll throw out another thing as a question that's going to maybe sound negative or provocative, and it's not meant to be, but I've had this discussion with people before, and it's been brought to my attention that maybe our own literature on this is now somewhat skewed into camps. And someone brought up to me one time, I can't remember if it was a resident or someone at some point of, you very seldom hear people who do joint surgery or joint replacement in the camp that's putting out research or putting out whatever it may be, advocating just jaw surgery. If I'm not, I don't know if I'm explaining that well, but it seems to be like there are people who do jaw surgery, but not joint surgery, who maybe lead the push and skew maybe the thinking because they just do jaw surgery. And so they find ways to justify or do jaw surgery maybe when
Well,
it should be. And again, both options are legit. We've said that, but like, do you feel like there's any truth to that?
I mean, it's like any fun topic. Like, it's not fun if you're like middle of the road, right? Like, you want people to be either extreme because then it's like more of an argument. Um, I think a lot of people practice in the way that it's a bit of a hybrid. The truth is, there's less people that do joint replacement than do orthognathic surgery.
Right.
And
I mean,
so,
that kind of leads to the ethical question, though. Like, should just because they're in your office, should you still treat them if that's maybe not?
yeah, I mean, because I'm sure there's very like practical reasons why you choose orthognathic surgery. And if you don't feel comfortable performing joint replacement, that's reasonable. And the flip side could be true as well. Like, you feel comfortable doing joint replacement, but you don't necessarily feel as comfortable advancing the jaws, right? Because those do seem to be different skill sets, even though I think they're the same skill set. Um, I think departments and people's practice um, can be split to, quote unquote TMJ patient or orthognathic patient, right? And so the subgroup of people who are adults who are opening up the upper airway and have condylar resorption kind of bridges those two, right? So
I mean, I could be convinced that the still pervasive negative mentality by a lot of people in our profession, the dental community at large, maybe even some other healthcare communities, the negative thought towards joint replacement and certain camps kind of pushing jaw surgery in some of these patients with maybe some medical therapies or other therapies first. I could be convinced that that skews people's like our overall knowledge and understanding and belief system about the best ways to approach this.
yeah, I mean the training of surgeons and the need for providers, um, it's all very regional. And so how people kind of practice, I bet it's different from place to place. And so like a topic like this, I think generally I'm in agreement that keeping the condyles is a good idea. And generally I'm in agreement that doing joint replacements is a good idea. You know what I mean?
Yeah, I do.
And I think most people would agree on that. But in practice, it's very much dependent on, what you're most comfortable with, what can be carried out technically. I mean, on the flip side of the spectrum, like a 16-year-old shows up with condylar resorption and is coming in for breathing better. I feel like the joints could be better managed medically. I feel like there's medical management of resorption that might be more appropriate than doing joint replacement, because bringing up TJR in the group of sitting down with the family and just talking about correction of an overbite is their eyes get real big, right? And honestly, I think unless they're hurting a lot, that subgroup, it makes a lot more sense to keep the joints. Like a 20-year-old lady with condylar resorption who doesn't have symptomatic joints is different than a 70-year-old. So I think I could get on board with keeping the joints and just doing mandibular osteotomies or ramus osteotomies much better
So I mean
based
that's I
on the
mean
the
it sounds
clinical
like you're
situation.
it sounds like you're describing ICR though. Is that what you're getting at or just any other kind of
Yeah, I mean, just whatever
invasive?
the cause is, inflammatory arthritis or just ICR in general. I think ICR management is a little bit different just because it's like a different window and different indication for surgery, right? I mean, obviously there's overlap to that in airway, but again, at the beginning, the idea of MMA is just, I can't breathe. I want to advance my jaws. And luckily, a lot of that's like middle-aged men whose condyles are in pretty good shape anyway, but not everybody.
So let me throw this at you. Maybe this is kind of steering this away from general MMA discussion here, but you get that 16, 17, 18-year-old with some form of condylar resorption and airway issues, and you know to treat the airway, hey, this is a teenage patient. They're not going to do a CPAP. They're not going to tolerate that. We're not going to put Inspire in them. Joints have some resorption, so an advancement appliance for them is probably not ideal. If you're not going to recommend joint replacement, like what are you trying to do to stabilize the joints to get them ready for MMA orthognathic wise?
Well, yeah, usually the nice thing about orthodontics is it allows you some time to stabilize the joints. I'm not in the camp of repositioning the discs to set them up like routine MRIs. If they have symptoms in the joint, stabilizing the joint just like you would otherwise makes sense. Like non-surgical stuff, surgical things if it's appropriate, like a chronic closed lock situation. But just from the patient showing up with a need to advance the jaws to breathe better and their joints look bad on imaging, I think you just manage the resorption after the fact. Does that answer it? Or
I
am I
mean,
skirting the
I kind of
question?
think so. I don't think you're intentionally skirting the question. The thing about quote unquote stabilizing the joints, I think is always something that maybe worries me a little bit because I think it can mean different things. And then I also think like there comes a point where you have to prove that they're stable. And I think that's not all that simple.
Sure. It's the same
Like,
discussion as condylar hyperplasia, by the way. Have you
yeah,
thought about how these two things like echo?
yeah, they're just in opposite directions,
Yeah.
opposite
Um,
extremes.
yeah, you get bone scan. You can do superimposition of cone beams. I think that's probably the best, by the way.
Yeah, I
But
mean, it's like,
you don't do that though.
no, I don't do that. I'll get bone scans. I guess for me, if we're doing joint replacement, then it's somewhat irrelevant, of course, right? And
Yeah,
then if we're doing MMA, then yeah, we need to find something, or we're doing orthognathic surgery, we need to find something. But I always it always in dental school, and even when I worked, you talk to your dental colleagues. The thing it actually kind of reminds me of, and this is going to seem like a weird analogy because it is, but it's my podcast. I'll say what I want. Is the old like, oh, the patient comes into the dental chair and their blood pressure is 180 over 115. And then you wait a couple minutes and you take it again and it goes down. And it's like, oh, it's better. So it's okay. It's like the moment in time matters. Like, if you take scans or you do these overlays and then you do the surgery 3, 4 months later, well, who's to say it's not worse now or it's not going to get worse in the future? You're getting snapshots in time. And I just feel like, what you said earlier for these patients holds true is you can call it a phenotype, you can call it physiology, pathophysiology, like they have a tendency towards this process. And I think kind of really leaning into, hey, they're stable now. Let me put them through jaw surgery and maybe orthodontics. And then hoping that to be stable going forward, I think is why I lean towards joint replacement.
yeah. I mean, um, what's great about this is patients have pretty strong opinions, so that can help drive. And if I think both ways are good treatments, then obviously, all else fails, talk to the patient. The the young person who has condyles that are functional but look bad on imaging um, is an easy group for me to get on board with doing sagittal osteotomy or ramus osteotomies. Just because I do think you can manage it after the fact. So, just because they had some negative remodeling in the past doesn't necessarily mean it'll happen in the future. But I think it does put you at risk for that. So as long as everyone understands it, the idea, I just am not on the camp of condylar resorption being something um, due to positioning of the condylar segment during surgery or fixation trouble. I mean, obviously you can run into trouble with that, but it's on the extremes, right? Like if you really medialize the condyle or lateralize it because your interference management isn't the best, Sure, but like that being the standard cause, I'm not so sure on, like just blaming the operator in terms of the mechanism of that. I feel like there's just joints that people that just their condyles resorb after these things, and catching it in the process and trying to intervene with normal methods, I think is a good route.
Yeah, definitely a good option. But I mean, as far as stability and how far you can move things and, Ramus morphology, I just
Because
Team JR, man.
I would also, yeah. Do you have a limit for the amount of advancement of TJR? I mean, it's
No.
functionally soft tissue envelope, right? Like, I mean, how much neck they have to advance. I mean, I think the most I've got out of it is about 4.5 centimeters with the TJR, and I wouldn't feel comfortable with that with L or Z or anything else, Sag. So I think the amount of advancement plays in a role here, but
Yeah, I mean, absolutely. And then not only the amount of advancement that you get, but relapse, after the fact, those extreme movements and not great condyles. I think you expect you're probably going to get some relapse, huh?
yeah, I mean, I think that hopefully we're making a plug that has people's interest in doing TMJ surgery to augment their jaw surgery practice, and TMJ surgeons out there to do some jaw surgery because they overlap like crazy more often than we think. Condylar resorption in MMA, condylar resorption in malocclusions, ICR, hyperplasia, condylar head tumors, previous surgery. There's good reason to be trained in both of those and to practice in both of them. Because I do think it makes these topics more interesting.
It does. But yeah, I'm with you. Like, I don't know that I don't know. I don't think I've gone 4.5 centimeters with the TMJR, but to answer your question, I don't have a limit, but I would not be comfortable doing some of the moves that I've done for like, ICR or severe resorption cases that I've done with Team JR. I wouldn't be comfortable, or I would be uneasy about doing that amount of movement
Yeah.
with typical
I,
orthodontic surgery.
I think the other group that I bet I know your answer to, but the concern that's out there that the condyles look bad on imaging, but they function well, is that they'll function worse after TGR. What do you think? Yes?
I mean, I think that is an actual possibility. Like I feel like that's more of a, maybe in my experience, yours I could see being different with more volume, but I feel like that's objectively that could happen. I feel like subjectively I haven't run into that. Like I haven't
Sure.
had patients say my function's bad or it's worse or it's a
Yeah, like
problem. But I
I
think
don't
if
have protrusive
you
movement or something, right?
yeah, if you were to measure excursus protrusives, I would say opening a lot of times I don't. Like most of the time they get really good opening. It takes some work, but they get there. But yeah, I think if you measure their excursives, protrusives, other things, you would objectively find that their function is worse. But I don't get a lot of subjective, hey, I'm worse functionally than I was before. Like I don't hear that a lot from patients. What about you?
Yeah, I mean the because for a long time I was trained to only do TJR on patients who can't move their jaw or have terrible pain or anything, right? But then you meet people who have relapsed from MMA or not MMA, yeah, let's say that, or just jaw surgery in general,
Right.
and they relapse in their condyles. And again, they're still relatively pain free. It's just that their condyles are keep going away, and so they don't want them to go away going in the future. And so then you put them through TJR, and it's really remarkable how their function is maintained. I think enough of those reps have kind of got me on board with the idea that it's reasonable. Because I mean, there's great people out there that practice in that way and are pretty big advocates for TJR and condylar resorption. And I think it's true. So
Yeah. All right. What else are we missing on this topic?
uh I
I
think
mean, there's
that's
kind of the
it.
two options. I mean, I guess you could. I mean, so you're not on board with there's been stuff published out there of you can arrest this or you can do, displications with orthodontic surgery, and that has a certain, likelihood of arresting any resorptive process that's going on. I mean, these things are out in the literature, medical therapy of what is it, antibiotics and stopping birth control and other things. Do you have
But
experience with doing those
but I
treatment
mean,
options?
that's more condylar resorption discussion. The patient who's shown up like my joints function fine, and I want to breathe better. They're not going to want to do a bunch of disc repositioning and whatnot as an initial stage. And to do that at the same time as MMA, I think is you're overcomplicating this scenario.
Right.
Um, I think the people who want to breathe better, to me, I have a number that I think is right, but I don't really um, I asked this of people, and I feel like most people answer about the same. What do you think is the real rate of significant condylar resorption after an MMA in people who already have condylar resorption? Like if you were just going to throw a number out at it, like the
So wait, people
concern
who already have condylar resorption, we do MMA on, what's the rate of that worsening essentially or reactivating?
exactly, yeah, like them going through the procedure and then relapsing to the point of needing another surgery, let's say.
Man, I'd say somewhere in the 10 to 20% range.
Yeah, I've been suspicious of that, and I think most people that I ask have that kind of answer to it because it's a hard one to know, right? Because it's you don't have 1,000 of those patients, and then you don't see infinite follow-up, right? So I
Right.
mean, how many people are running around with a little bit of excess overjet, but they're still breathing fine? Probably a lot. Um, I think the absolute long-term follow-up is unknown when it comes to these things. But if they're getting along fine, they don't need another surgery.
That's my, yeah, I frequently have that refrain with patients about all these modalities that, have questionable efficacy or that come in and out of vogue. And it's just, I always tell them that my perception is skewed because if they work, I don't see them. Like
Yeah,
if someone else does jaw surgery who doesn't do TMJ surgery, does it and they don't have a problem, like I don't see it. I only see it when, okay, someone did jaw surgery, there's a problem, they don't do TMJ surgery, now it's in my practice, and that skews your perception heavily.
yeah. And so I mean, I feel like 1 in 10 is a reasonable number, and there's definitely a part of me that 1 in 10 is it's a high risk in surgery complications, like it's one that's in the higher rate. Because most of the things to get concerned about are low digits like non-union or infection, right? So it's there, but it's not like such a high rate that you should be doing joint replacement all the time. Like if you do TJR in 10 patients to help one person's problem, you're overdoing it. So I think it's to finish off, I feel like we've been a little bit too promoting the TJR pathway because I am in agreement on that path, but the alternative argument makes a ton of sense based off of I think that. So I don't know. I think it's an unknown number, but I do feel like that's about right. So
You may be right. Yeah, I mean, I do skew that way, so that's probably why it comes out that way.
we're all biased,
We are. I
stinking
mean,
surgeons.
you
Um,
you mentioned you get that patient, and what would I do if it was my sister, my wife, or whatever? I think I would hope we would all agree if someone gives you that exact same scenario and says, "Hey, you got one operation to get this right. Which one are you picking?" You're picking TMJR every time, right?
um, I think from the experienced hands, I would think that's correct. Yeah. I mean, I answer that question like TJR. I think that's the right approach. I think it's the most likely one operation. So,
For
but
sure.
anyway, I think it's an interesting topic. I think you're gonna end up doing a sagittal osteotomy in that surgery, I bet.
I am.
Yeah, man. It's
I am. And we'll
the real life
as
stuff matters.
as the first surgery, I'm gonna be doing sagittal split. The second one will probably be TMJR.
Let's see.
But
I think that's about it. I think shorter conversation on it. So that was good.
well, man, one last question. Then
Yeah.
we're gonna do you do anything different? So like you have a condylar resorption patient who you're doing MMA on. Do you do anything different when you're doing the orthognathic surgery? Like, do you do anything different with your sagittal split? Do you do anything different when you're planning?
Oh, because of the condylar resorption?
Yeah. Do you take any other
Um,
precautions? Do you overcorrect more? Do you do anything else?
this I'm probably overthinking this one a little bit, but I'll tell you how I currently practice. So there's like two competing relapse things in that scenario. Because MMA, generally the unstable jaw is the upper jaw. The upper jaw wants to drift back. You know, your plan is limited by the amount of maxillary movement most of the time. And so if you're doing a centimeter, 15 millimeter in a maxilla, centimeter, 15 millimeter in mandible is not much. Maxilla, it's a lot. And so the maxilla want to drift back. The posterior maxilla want to drift up. Anterior maxilla want to come back and up, right? And so in this subgroup of patients with condylar resorption, I'm sorry let me complete that thought. So generally with MMAs, I actually leave them a little bit class 2 to allow for maxillary relapse. In the
Okay.
subgroup with condylar resorption, I don't tend to do that because I think
Okay.
both jaws will have a tendency to relapse. Not
Okay.
not that I want that to happen, but there is a little bit of fudge here, like the half millimeter, the millimeter difference in your plan, which that'll be for another episode. But in the condylar resorption MMA patient, I think both jaws will want to relapse a little bit.
Okay. So you think the relapse, whereas normally you would set them up class 2 in an MMA case, you would do not that. You would just try to place the occlusion as ideally as possible because you're
Yeah.
anticipating a certain level of almost near equivalent relapse in both jaws.
Yeah. And it's always hard to anticipate relapse. But at the same time, planning on everything healing perfect on the extreme movements is optimistic. And so I generally think those two offset. So that's how I practice now. Do you do anything like that?
Now that you've said that, I feel like, I would say again, you're correct in my bias, and I tend to do more TMJR in these scenarios than I do orthognathic. And I think I don't know that I do anything different, but what you're throwing at me makes a lot of sense. Because I do in MMA tend to make them a little bit more class 2 for the reasons you said. But I don't know that I've thought about it, factoring it in any differently for condylar resorption patients.
Yeah, I mean, um, they kind of complement each other. So from that view, it's not terrible.
Yeah. So for the relapse in each jaw, you're kind of saying it's like 6 in one hand and a half dozen in the other.
There it is. Old man saying,
We
glad I
need to
got it.
catch up. We've been
I
lacking.
we have been. The oddball one, which I continue to flirt with this. I don't know if I have enough reps to really advocate for, but to throw out an idea is releasing the coronoid in condylar resorption patients. So maybe I'll just leave that dangling, but I have certainly practiced in that world. So um, anyway,
Okay.
I think for MMA, I might add that in as the other thing that I would do.
Interesting. Okay.
So,
All right.
all
Well,
right,
you want to
man.
wrap it there?
Yeah, I think it's good. I think um one of these, I think we have some guests lined up here. It's October already. You do you do Halloween?
So I do Halloween, man. I was putting up decorations and stuff yesterday. It was awesome.
Do you have
We
your
got this
Halloween decorations up
new.
right now?
Oh yeah, man. Yours aren't?
No, I got next weekend, I think. It was a good weekend for it. What do you got? You have one of those giant skeletons?
Oh man, I don't have the giant skeleton, although I always every year I let the kids go with me to Home Depot when we each pick out a decoration. And every year I see that thing and I want it so bad. It's just
How
hard to
did you
justify. It's like 400 to 500 bucks if I remember correctly.
It's
It's like,
expensive. It also is ridiculously big.
yeah,
Like you
like where
need
do you
some
keep it?
serious storage. Yeah, totally.
You
Like you
almost
just
have to leave it out and incorporate it year round. Like
totally.
it's so much easier than put up. It becomes
Yeah,
you put a Santa hat on it at Christmas or
Christmas skeleton and
turkey
St.
feathers on
Patrick's
it.
skeleton and
Yeah.
Independence Day skeleton. Yeah, I mean it's I have one of those and it's so ridiculous. It takes
Wait,
up so much
you
storage.
do have the giant skeleton?
Yeah, we got one as a gift. I was gonna say a couple years ago.
Like the 12
Um
foot tall, 14-foot tall one?
yeah, the Home Depot mega skeleton. And it takes up so much space. Like it's in our garage and it's silly. So anyway, I got to get my Halloween decorations out. But from the podcast side, we'll have some guests this month, so that'll be good.
Hopefully. Yeah, the the other Halloween decoration that I got this year that I put up yesterday that's pretty legit is it's a projector. I think I got it online somewhere, and you put a screen up in one of your windows, like a white screen that you can tape to the window,
Yeah.
and you have the projector which does it in reverse. So from the outside you see it. And it's actually Halloween and Christmas, and there's like four different things you can view for each holiday. So like last night it was like a guy with a chainsaw who's like running around, and there's like a dancing skeleton and
I
like
mean,
four
that one sounds solid.
weapons. It's pretty legit. It wasn't that expensive, and it was actually pretty easy to set up too. So it looks pretty cool from the outside.
Nice. All right. Well, um, yeah, I thought I'd usually October is what prompts me to do that, but I'm a week
You haven't
behind,
even
I
started
guess.
watching Halloween movies yet?
No, dude.
God, man, I
I know.
don't even know who you are.
Well, sweet. I think that's it for today, huh?
All right. Yeah, another Down Fracture podcast, downfracturepodcast at gmail.com. Check us out on YouTube, Instagram, Spotify, Apple Podcasts, whatever. And I'll see you next week.
All right, man. See ya.
All right. See ya.